So a lot of this talk actually is going to pick up some of the themes that Robin just so well outlined for us and talk a little bit about lessons from the PROTECT study. For those, Jim talked about the risk study this morning. PROTECT is the birth child of the risk model, a study now funded through the National Institute of Health, looking at translational material in newly diagnosed children with ulcerative colitis, but moving beyond just the translational part of risk and adding a protocolized treatment algorithm to the treatment of ulcerative colitis, so we can hopefully learn who is going to be the ones who have the most aggressive form of ulcerative colitis, and look at our therapies today and see how we can maximize them. And I'm supposed to talk on what we have learned from that. So my disclosure. So yeah, you have to do this, right? The pathogenesis of IBD, it's this synergy between your innate immune system and your genes that Judith so well outlined this morning, your gut microbiome, which Jim told us about, and then environment, which David outlined so beautifully this morning. So we all understand where IBD comes from now, and we're looking for the many genes. The one thing that hopefully we'll all leave here today is a recognition that there is no such thing as inflammatory bowel disease, and it's not just two diseases. There are many different forms of the disease. And as I explain to my patients, and I keep reminding myself, I think of diabetes as the model, right? Diabetes means your blood sugar is high, but we recognize this type 1 and type 2. How the etiology of it is totally different. How we ultimately treat them are totally different. And to just say that the patient has Crohn's disease or ulcerative colitis really tells us nothing. If there are 168 or 191 or 6,433 genes, it can't be that it's just two diseases. It's too complex for that. And as we get to know more and more, we'll be able to stratify our patients, look at markers, right? The goal would be we'll have a chip, we'll take a drop of blood, put it on, I'll know their genes, I'll know their serologic response, scoop of poop, I'll know their microbiome, and I'll know exactly what therapy that patient has, and whether we call that IBD type 1, 2, 3, 4, or something more imaginative. We're going to get to a model where we actually have targeted therapy as opposed to the one-size-fits-nobody approach that we've been doing for so long. We talked about the importance of making the correct diagnosis and some of the pitfalls, and making sure that if we label someone with IBD, they truly have IBD, and once we do label it, getting some sense. And to me, I think the most important thing between the Crohn's UC paradigm is, do we think you're going to have a mucosal disease, or do you have a disease that ultimately can go transmural and have the complications of that? And perhaps that's the most important question that we need to ask ourselves in a patient, especially when they have isolated colonic disease, as we see in our young children. We've come to recognize, I already alluded to the fact that I'm obsessed with the words that we use. I hate the word flare. I think it's the stupidest word that we use in IBD. I've had many patients teach me that. One who was very sick and then called me. I said, why don't you call me? He said, well, because it was a flare, so I thought it would just burn out. I was just waiting for it to burn out, and it just kept getting sicker and sicker. I think it gives the patients a sense of dread. I'm walking along, I'm doing fine, but at any moment I could get shot with this flare. And if you look at it historically, we talked about the history before when we talked about the diets. Where does the term come from? It comes from the old days when all we had was steroids. So the treatment was worse than the disease. So the patient was given steroids until they felt better and came back begging from the side effects of the steroids. Doc, get me off the steroids? Fine. I'll taper off the steroids, and I'll wait till your disease flares, and I'll put you back on. And that's why all the literature says that these are diseases with remissions and flares, because historically, that's how we treated them. We're so much better than that now. We have therapies that we can induce and then maintain a durable remission, and that's what we're really shooting for, as opposed to, I'll just quench the flares. And now the language we're using is more proactive as opposed to reactive, which I think is fantastic. This whole fakakta pyramid thing that we used to believe in, step up, step down, what we're really learning much more is it's better to step in. And if we know what disease you have, we'll step in with the right therapy, we'll optimize it, and you're going to do well. And I want to make a real pitch for treating the whole patient. You've heard a lot of that. We talked about it in the cases that we presented before. Taking good history and physical will not only set up you to understand better what's going on with your patient, but what's going on with your patient. I'll show you some data that I think is really compelling about the importance of treating the whole patient. So we all stare at these slides. We showed them at this meeting. You'll see them at every meeting. You know, the difference between a drug in a clinical trial and the placebo effect. And we always highlight the bar that shows you what the drug did. But what I'd like to call attention to is the placebo effect in all the clinical trials. And why is it so high? Because just taking care of a patient makes them feel better. And so sometimes the best combination therapy we have to offer is holistic psychosocial support of our patients, in addition to decreasing the inflammation, because our guts are connected to our brains, and the mind-body connection works as much in our inflammatory patients as it does in our functional patients. And I would put a plug into how we speak. When we talk about drugs, you know, the patient who failed a therapy, no one ever failed a therapy. Therapies fail the patient, and patients don't flare, they fall out of remission. Just some of my bandwagon things. All right, so what is PROTECT? So you know how trials are named. You decide what word you like to use, and then you try to make the letters fit. So this, we wanted to call it PROTECT, so it came up with predicting response to standardized pediatric colitis therapy. Did you know that's what it stood for? Yeah, you're better than me. I have to look at the slide to remember. Yeah, right. So yeah, you forget that you don't remember. So some of the interesting data that has come out already from the PROTECT. So this is a very well categorized cohort of newly diagnosed pediatric patients with ulcerative colitis, and looking at the data, most of which is not yet published. So you're getting a sneak peek here. This is from the first 379 patients that were enrolled in the study. We're approaching the 400 mark now. And you can see that in general, I do have a pointer we decided, right? Oh, here we go. We're about 90% getting into the cecum. If we look at all our colleagues across the country when they newly diagnose ulcerative colitis, that's not always technique related, right? Sometimes you have a really horrific colon that you don't even want to try to get to the cecum. But about 90% of the time we're getting there, and 2/3 of our patients are inflamed all the way across or have a pancolitis. And interestingly, there is extension microscopically in about 7 to 8% of the patients who don't even have macroscopic disease there. So we can then start thinking about, as Robin was talking about when we talk about mucosal healing, well, what about how much of the mucosa is involved at the beginning? Is it important if you're pancolitic microscopically or macroscopically, and is there a difference? Just many questions that we can start asking from this cohort. What about some of the non-classic features? So we all tell ourselves that ulcerative colitis is continuous from the rectum, but about 8–9% of the patients had relative rectal sparing, but they did have biopsy microscopic involvement in the rectum. Macroscopic patchiness, especially in the beginning, you can see it. I'll also caution that's another thing that you'll see a lot of, a pitfall. A patient who was diagnosed with ulcerative colitis now isn't doing well, gets rescoped, and the disease looks patchy, and they change the diagnosis to Crohn's disease. No, that's a patient who has patchy response to your therapy for their ulcerative colitis, so don't get snookered by that one. We recognize that the cecal patch or periappendiceal inflammation is a form first of ulcerative colitis and not a reason for that discontinuous phenotype to be called Crohn's disease. Backwash ileitis was seen in about 7% of this cohort. The other thing, since it is routine amongst pediatric gastroenterologists to scope up both up and down when we diagnose ulcerative colitis, recognize that more than half of the patients had microscopic gastritis, and actually more than 25% had gross disease in the stomach, but still were ulcerative colitis. So don't be fooled and call that Crohn's disease. This is the algorithm. It can give you a little bit of a dizziness from the back, but I think we could all agree that this is how we think we would treat ulcerative colitis. If you were mild, I would just induce you with mesalamine and hopefully be able to maintain you with that. If you're more moderate to severe, I probably would induce you with steroids and then try to maintain with mesalamine, and if not, go on to a second-line therapy, such as an anti-TNF or immunomodulator. And if you were more sicker and came in severe or fulminant, I probably would put you in the hospital, treat you with IV steroids, and go on from there. So is that this is the protocol. We all signed in blood. This is what we're going to do when we put our patients in the PROTECT trial. And indeed, is that what we did? Well, maybe not. And I would highlight that about 2% of the patients who were called mild actually had induction in the hospital with IV steroids, whereas about 2% of the patients who were severe actually got induced with mesalamine. So even when we think we're doing it the way we think we're going to do it, we don't do it that way. So it's so interesting to study yourself and to look what practice patterns across the country actually are. in even more than 25% of the severe patients, rather than being put in the hospital, were actually started on oral steroids. So it's some lessons perhaps to be learned about optimization of therapy. What is the whole point of risk and protect? It's to recognize that there are different phenotypes of these diseases, some which just sort of smolder along, some crash and burn, and it's probably the patients who get very sick very quickly that we would like to be more aggressive up front and not try this little piddling along while they get sicker and sicker, whereas we don't want to throw our best therapies at patients who are never going to get sick. And so some of the things that we've already decided upon from risk and other studies that we know are patients with Crohn's disease who tend to do poorly. As Robin mentioned, the patient who has deep ulcerations on endoscopy. If that's a disease that has a tendency to go transmural, if you're kind of transmural the day I diagnose you, you're probably going to be a bad actor. Patients who we give our best therapies up front and they have poor responses, so they're already saying I'm treatment resistant, and perhaps the geography, the amount of bowel that's involved predicts poor outcomes. If you're older and have more growth impairment, you're going to do less well, and that translates into your bones being sick, and certainly perianal disease we all recognize. Robin already talked to us about treatment to target, and the basic concept there is, right, I'm going to do a regular assessment. I'm not just going to ask Johnny, how do you feel today, and take that as success. I'm actually going to measure and look at how the disease is responding to the therapy. Then the devil comes in the details. So I look at stool markers, blood tests, do I have to scope everybody, et cetera. What exactly is the target that we need? That's what we're all debating about. We talked about loss of response on therapy, and that patients certainly do lose response over time. And some of the strategies that we know that will optimize our outcomes are regularly scheduled maintenance of our biologics, concomitant immunomodulators, but it does remain an open question. If you start 2 agents, do you need to continue that forever? And we talked a lot about drug monitoring, and there's going to be a lot devoted tomorrow about that, so I will save that for tomorrow. Marla's probably going to show this because it's her work, but this was just a test of concept, looking at that 14-week infliximab level. So I put you on your maintenance therapy. Shouldn't I get a level at that point to see if I get good drug levels with that? I could tell you I've adopted this. It works fantastic. The one thing I do also then is repeat it at about 6 months to make sure, because I'm not sure you get a steady state at your first dose of maintenance therapy. So I like to see that you stay in steady state and we have good drug levels. This was a Bill Sanborn study. It's also a test of concept. Is mucosal healing achievable? So this was regularly scheduled colonoscopies. I'm going to keep looking until I heal your mucosa, and the patients really did very well. There was a very high rate of sustained remission, but I would point out that these 67 patients underwent 161 endoscopies in a year in order to achieve this. I'm exhausted just thinking about doing that in all my IBD patients, and certainly our system can't afford that. So we need another way to figure out this mucosal healing idea than just to keep scoping everybody. So in summary, hopefully in time and in a clear manner, I've been able to impress all of you that we actually are talking about more than just 2 diseases, and I think the very early IBD work certainly brings that home, that there's a whole host of diseases. And what that means when we talk to our patients is we will find cures, not a cure, because we're dealing with diseases, not 2 disease. And that accurate diagnosis and staging up front is going to bring us our best outcomes, and that the ideas of treating to the target and knowing what that target is going to be, and until we get there, we should be treating the whole patient to optimize our outcomes. Thank you.